I'd like to introduce the first of two panels this morning that fundamentally are similar in direction but are going to filter through two perspectives. The intent of these two panels is really to look at, as Barry explained this morning in his opening remarks, we spent a lot of yesterday talking about a vision of researchers' care and care as research. And today we're really digging in deeper into how we can start to implement and think about embracing this concept into our own system. And with many thanks, of course, to the Australian model, we have many, many great benchmarks to move forward through. So this first panel really is going to explore the concept from a ethics, cultural change, and training perspective. The second panel is going to explore this idea from an operations, logistics, and regulatory perspective, which we'll come to. So this first session is chaired by Dr. Stephanie Michaud, who's president and CEO of BioCanRx, also a co-chair of this conference. She will be joined by Susan Marlin, who's the president and CEO of Clinical Trials Ontario, and the nominated principal applicant for the CAN Review collaboration to establish a pan-Canadian single research ethics review system supported by CIHR-funded Accelerating Clinical Trials Act initiative. Dr. Rebecca Barnes is the executive director of the Network of Networks, better known as N2, a national organization focused on strengthening and advancing clinical research capacity across the country. Dr. Stuart Nicholls is a scientist in the Methodological and Implementation program at the Ottawa Hospital Research Institute, where he leads the Office for Patient Engagement in Research Activities. I have to say, though, Stuart, I was reading your bio, and I have to put this in. He is also the purveyor of many dad jokes, which are generally tolerated by colleagues and his 3 teenage children, so perhaps you can start us off with one today. And Dr. Dean Fergusson is the Deputy Scientific Director and Senior Scientist at Ottawa Hospital Research. Please welcome the panel, and over to Stephanie.
Thank you so much, Anne-Marie, and I'm very excited to be here and to launch this first panel today on the continuation of the great discussion that we had on day 1 on research as care and care as research. And it's really about more than semantics. It's really about reimagining the culture of healthcare so that research isn't something extra, but part of every patient's journey. And that's really what we're talking about here today. And so as we've heard on day 1, as we're going to continue to discuss today, and thank you again, Kurt, from the bottom of my heart for sharing your incredible experience. We have a lot to learn from Australia, and I'm sure you're going to be getting a ton of emails in your inbox over the next couple of weeks. And part of the discussion that we're going to continue today also is how to embed clinical trials into standard of care. And this is, of course, a recommendation that we've been discussing yesterday, especially later during the day when we touched on the Canadian Cancer Society clinical trials report and how this could really transform access, equity, innovation in Canada. But doing this, accomplishing this phenomenal goal, will require not only operational shifts, which we're going to explore in the panel after this one, but also profound cultural, ethical, and educational transformation, which is what this panel is going to be discussing, or the really hard part, which is the human side of change, because we all know what eats something for breakfast? Culture eats strategy for breakfast. So this is a really tough challenge. So thank you, Anne-Marie, for introducing our panel. I'm going to set the stage on the subject matter of this conference, which is, what do we mean by research as care and care as research? And I'm going to ask Dr. Fergusson to kick us off. And the question is the following. What does embedding trials into standard care look like in practice?
Yeah, so I see the research embedded into care as working towards that learning health system, where we build a collaborative and continual platform for learning and improvement. And two key factors in there, and when I say collaborative, it's not just within the interest holders within the health system, but it's with patients and those with lived experience. Two key ingredients to that to that learning health system are patients and data. And Canada has made, I think, extensive progress in both those areas. In data, in terms of having electronic health records, electronic medical records, administrative data, trying to get them to speak with each other within provinces, across provinces. We still got a ways to go, but the seeds are there. And then, of course, with patient engagement through the strategy for patient-oriented research, learning from the UK, learning from the States, not necessarily now, but before. We've come a long way, and those are two ingredients that will form the learning health system. So if it's hard to wrap your head around a learning health system, it's essentially if we embed patients within everything that we do in research in a hospital, a learning health system will develop with the data, of course. So I see that as a necessary platform that we're working towards, and ensuring that every patient has access to research and is part of research, not just through data, but as you say, through clinical trials and standards of care and so forth, that are not there right now. A very small percentage enroll in research or participate in research, even a smaller percentage enroll in clinical trials and so forth. So by creating that ecosystem, I think that provides the foundation for embedding research into care. And I'll also say that the Ottawa Hospital, you walk through the doors of the Ottawa Hospital, it's very hard to determine whether research is happening or not. We've got a long way to go, and that hence the cultural training and the institutional buy-in in that research is care, and that we need to promote that through all four walls of the hospital and through clerks all the way through to administration, to the clinical teams, the researchers, and the patients and community members as well.
Thank you, Dean. And I'd like to then ask my next question to Stuart. And Dean, you've touched on some of these elements a little bit. And it's really with respect to the boundaries between research and care today, how we're situated. Do they still make sense?
I think that depends on the perspective you bring. So to give you an example, we did some work where we spoke to patients and patient partners on pragmatic trials. And one of the things that came through was different perspectives on those barriers, depending on who we spoke to. So, for example, from the patient perspective, they said that difference between research and care doesn't exist for them. It's part of their health trajectory. It's part of their whole experience as a patient. And to sort of try and separate out research from care, it's all impacting them. Whereas for the researchers, it was very much about those regulatory burdens, the administrative side, and sort of saying, well, why is it that things that we're labeling as quality improvement require one set of procedures and those that we label as research require different, even though on the face of it, their processes and things might be very similar. So I think that was, it makes sense maybe if you're coming from a health system perspective where you have to kind of put things in boxes to make things happen. But from the actors on the ground within clinical trials, it really is a blurry line. And so I think we need to think about how do we best implement oversight, which may include bringing things into oversight that aren't there, or do we separate them out? But I think they are increasingly blurred lines from a number of perspectives.
Thank you, Stuart, and which is a great segue, by the way. So if we accept that research and care are intertwined as you've just described it, how do we prepare people, clinicians, patients, and ethic boards to work in that reality? And I'd like to turn it over to Susan to to further frame this with respect to our ethics frameworks, and how should they evolve to support research embedded in care, balancing protection with opportunity?
So just picking up a bit on what you just said about that, the research versus care. Many of you will have heard in the ethics community the phrase therapeutic misconception, right? And therapeutic misconception is when an individual is participating in research, like a clinical trial, and they think it's care, whereas it's supposed to be made very explicit. This is research. It's not necessarily to help you individually. This is not care. So when we say research is care and care is research, that's kind of a fundamental sort of piece I think we need to resolve between the way patients think about research when they're going on it and the way that ethics boards view that piece. I think a lot of the, I'm not sure what, I wouldn't call them barriers. I would say a lot of the conditions around research versus care, when we talk about the regulatory hurdles and all of these things, it flows down, I think, from that very entrenched distinction. And when ethics boards are doing their work, and by the way, there are people on ethics boards, I see Natasha over there that know a lot more about this than me, but they're really concerned that individuals really understand what is happening in a research study, that they fully understand and fully consent. And I don't think there's one of us that would argue with that piece. So when it comes to changing the culture around research and care is research, I personally believe the patient, the public voice is going to be absolutely key in this, like absolutely key. REBs do their best every day to ensure the rights and the welfare and the expectation of potential patients or participants is considered. So that public voice coming into this discussion to say what they expect and what they think about things, if they see research as care and care as research, that's a powerful message to be coming forward to help things move along. I have other things more around structure, but I'll leave those later. But that's it. Thank you.
Thank you so much. And so, going back to you, Stuart, on the subject of ethics and autonomy, how should consent evolve in a world of continuous learning and real-world data?
Yeah, so I think we hear a lot of discussion, certainly I do, in terms of using things like waivers of consent, so doing studies in using designs that allow us, or hopefully move to that. And I think we have to be careful that we don't create a false dichotomy, that it's either waiver or this, again, this sort of caricature of this 50-page written consent form. We have approaches. We've had evidence for 20, 30 years about alternate ways that we can get consent for clinical trials. What we haven't been good at is implementing it. We know, approaches to verbal consent. We've got streamlined ways to embed documentation of consent in electronic medical records. We've got all those things. We've got electronic, decentralized trials. Can do e-consent for those now. But we haven't been good at sort of following through and making sure those get taken up in practice. And I think that's the big change. And part of that's education. Part of that's interoperability of sort of figuring out how do we get this within the system that meets the regulatory requirements. So I think we have a lot of the pieces there. We just have to figure out how to sort of get over the hump and get these things used in practice.
Mm-hmm. And I see engagement of the public as being so important. When I am asked about clinical trial vision in Canada, in my statement is always, I want patients to expect clinical trials to be part of their care routinely, that this will be part for the course, that this is an option that will always be available to them, no matter what. With respect to data-driven, and this is a question for Dean, and it's to ask you if there is an example that you can think of where data-driven care challenged traditional ethical boundaries. And open to the to the entire panel if they have an example to share with us.
Yeah, so I'll start by just re-emphasizing what Susan said is those safeguards have to be in place in terms of the distinction between research and care. And I think that's where, in terms of data-driven, one of the challenges right now is the efficiency of doing clinical trials. So I'll give a trial example, is that we have routinely collected data, we have electronic health records, medical records. We're not using that data directly for clinical trials, right? So there's no need to go collect this data, research nurses, research assistants, research staff, to look into those records to collect that data when it's already routinely collected. And so there's huge efficiencies by using provincial databases, local health data, and but it has been, you need all the safeguards there. You need to get through those regulatory and policies and procedures with the data, and we need to knock down some of those barriers. I think we can be much more efficient, especially with provincial administrative data. It's the timeliness of it. It's not real time, and I don't think it will ever be real time, and it doesn't need to be real time, but it can't take. So for one of the trials where we use registry data, it took over 2 years to get the data. So that's 2 years of not getting those results out to the health system. So I think that's where it is, but we're moving in the right direction. In your direct question is all the regulations and policies around privacy, confidentiality of using that data, but that's what we need to work on is knocking down and having efficiencies there. I don't. The area does pop up, though, will be that divide between quality improvement, where there's, let's just say, less checks and balances, and research. And to me, there's a big gray area that we just need. Again, we need protections, but we need access to that data, more efficient access to that data.
I couldn't agree more. And so thank you for that. And excellent example. Are there any other examples that members of the panel would like to share on this subject before I move on to our big subject of cultural change?
I'll maybe give one other example of sort of how we have to be sort of mindful of, and where the patient engagement actually is really important when we think about the specific aspects of a trial design. So we work with a number of patients to look at how we can, in the hemodialysis context, to look at how we can apply ethical principles to try and give concrete case studies. Because one of the things we're hearing from trialists is like, how do I apply these things in my practice? How does this actually work? And they're really looking for those concrete examples. And so we had an example of a trial where we spoke with the patient partners and saying, oh yeah, there's posters up for notification to tell us this trial's going on. But they put it behind the weighing machine because everybody gets weighed. But the reality is when I'm being weighed, I am so petrified of my weight and whether I'm going to be told off for gaining weight. I'm not even looking around. So the idea that this serves an ethical principle of notification just didn't work in practice because the way it was put forward didn't recognize the context. And we also heard from those patients that actually they often request their own data from their hemodialysis session. And so again, if we think about waivers of consent and trust in research and those sorts of things, if they see a change in their data and they then go, what's happened? If they've not been told about a trial that they're involved in, what's the implications then for trust? So again, I think we have to think through and work with patients to understand the context, to understand how we work through these ethical questions.
Thank you for that. So on the subject of cultural and institutional change that's required, ethics, of course, are essential. Having clarity there is critical to engender trust. But culture, as we've often heard, eats strategy for breakfast and often determines whether good policy succeeds or stalls. So we're going to explore this. And I would like to turn it over to Rebecca for this discussion, really important discussion on cultural and institutional change. And on the subject of incentives and on the subject of leadership. What are these leadership and incentives that we can provide to institutions, to researchers, to clinicians to help normalize research participation?
I think one of the biggest things that I have seen work well is to make it action-oriented. And so I had the good fortune of, like, too long ago now, probably at least 8 years ago, helping to establish a permission to contact program at Island Health, which is the only tertiary care provider on Vancouver Island. And our design, which wasn't opt-out, it was opt-in, which obviously has its limitations, opt-in that is. But the nice thing about it is that it created a reason for registration clerks, nurses at bedside, and others who are in purely clinical roles with no historical research function to actually first be trained in the notion that the care you're delivering today, and this system is delivering today, is because of the research that was done 5, 10 more years ago, and you have a role in, you know, paying it forward and making sure that we keep moving that dial. And so by having those individuals, one of their responsibilities added was just this quick conversation with patients every day, multiple times per day, about the simple question, may we contact you for research, and can we screen your health record for those purposes, really was a huge part of moving that organization towards more of a research as care culture. Still, of course, a way to go, but it was a really impactful way. And so the way that we got at that was both top-down and bottom-up. So obviously having those conversations with the CEO and board of directors and those in charge of the electronic health record to get, you know, places added for research, which was a really important culture-changing moment, because the idea that on page 1 of the AHR in an organization where research had really been a very small, minuscule activity, was on the first page of each patient's record, was huge for people sitting at those tables. And then the bottom up, going and training individuals working in clinics and making sure they were ready to engage in those conversations, answer questions, et cetera. So that was one example that I wanted to highlight. But following on your point, Stephanie, about patients expecting that clinical trials opportunities would be part of their trajectory whenever they interact with the health system. And I think it's come up today. Certainly it came up at a conference I was at earlier this week, is around the public awareness piece. And so I think, Kurt, you spoke about this too in Australia. I mean, every country grapples with this. But just to say, I think that would be probably the biggest lever in terms of culture change. If patients showed up, more patients, I should say, some of course already do, asking those questions about what trials are available to me, you know, I think would be huge. And so I did want to highlight, because I just learned about it yesterday, the NIHR in the UK has launched a public awareness campaign called Be Part of Research. If you Google it, you'll find it. And it looks excellent, and I think would really ratchet up smaller efforts that we know have existed in Canada for some time into the organization I work with has a public website called It Starts With Me. In Alberta, there's Be the Cure. In BC, there's Reach BC. So there are efforts to do this, but having a national initiative and one with investment federally would be amazing in terms of getting at that major culture change, which is huge.
I couldn't agree more, and I've seen the signs on the bus in the UK, so you know it's advertised and very much part of the day-to-day there in the UK. I wanted to ask about the really important example that you've provided with respect to opt-in and engaging a multitude of different staff. How was that reflected in the hospital's KPIs for performance? Was it right? What did it do to staff satisfaction? Was that captured in HR surveys, for example? Did that move the needle in any way with respect to performance, with respect to the experience of the individuals working in that hospital? How is it captured at these different organizations to make this shift?
Yeah, so Dean may have more to add because I know that you have a more current experience with permission to contact programs. But when I left Island Health, it was not, sadly, a KPI for departments that drove budget, for instance, which would have been amazing. But certainly we did survey staff around the satisfaction piece, and we did see that change. Really interestingly, and I'll be quick because it's a bit of a tangent, but what I found so interesting was the difference in both participant response to the question that seemed to be inherently driven by the culture within individual units and departments. So I'll give you an example. In the multiple sclerosis clinic, pretty much 100% of people walking through the door were asked the question, and over 95% said yes, which I think is healthy. You don't want it to be 100%, right? So I felt like 95 was probably about perfect, versus the Diabetes Education Center, where the ask rate was more like in the 20s, and the acceptance was also not so high. And so I think, didn't do a study on it, would have loved to, but I think there's really important questions to understand there about the drive, the motivation of different patient populations. For me, if I have MS, I'm going to be really driven to make sure my kids and future generations aren't going to, befall that same outcome, versus diabetes, chronic condition, highly treatable in many cases with dietary interventions, et cetera. And also the motivation and commitment of the people who are having the conversation. Despite our training and scripts that were REB approved, et cetera, we know that tone and just excitement would really shape the nature of that conversation.
I just wanted to pick up more on the folks and whether or not they implemented the program. And I think many of us have been involved in trying to implement programs in research institutions, hospitals, et cetera. And, in the Canadian context, setting aside there is legislation, a few other things that dictate some things, but for the most part, it's institutional leadership that decides what's going to happen in the institution. And this came up yesterday. It might have been you, Vachi. I think it was you that brought this up, which I think is a critically important point. Most of the things that we're talking about today in so many other forms could be implemented, assuming enough money and resources, but implemented to the extent possible if institutional leadership says make it so. By the way, saying make it so is just the first step, though, and this is what we often see too. Institutional leadership all says, yes, great idea, sit around a table, pat on the back, we did really well today, we made some common decisions. However, if there's not real follow-up and support from that leadership and recognition for the work that gets done, it has the chance of being delayed significantly or even failing. And I think part of what we have to be building into all of these things is once we get that institutional leadership buy-in, the next step is for them to have an institutional action plan for implementing it, which ideally goes back to the KPIs and their bonus. By the way, I don't know if they get bonuses. I made that part up.
I think they do. I think they do.
The leader's ears perked up there.
What? People get bonuses?
Yeah, so well said, Susan. That's what was percolating. My thoughts are it is the leadership of the institutions, not the research institutions or the universities, but the hospital leadership and the health center leadership. They need to buy in, they need to embrace it, and then set out an action plan, like you say. Because right now, even the permission to contact, which is largely done through the clerks, some research staff now, but largely through the clerks, it's not in their job descriptions. It's not in the job descriptions of, at an academic health center, such as the Ottawa Hospital, within the nurses, within allied health, within administration, within the clerks, orderlies, et cetera. It's not in their job description, research. So we're working on that, and because that sets the stage. And there's, that action plan is large, but it only gets started when the institutional leadership believes that research is care. Yeah. And then we can start making that happen.
And buys in and implements, right? So very standard management practices that the vast majority of us are keenly aware of. Stuart, before we go on to discuss training and capacity, I wanted to ask you, because we've been speaking about what leadership can make happen. And Susan, I wanted to say, I think we're going to start a campaign. It's going to be Make It So. Make it so. So I just wanted to plant that with you right now. Stuart, we've spoken about the top actioning this, but we've also heard over the past 2 days how important it is for the bottom up. And so I wanted to ask you, with respect to the work that you do on patient engagement and community trust, how does it fit into this cultural shift, especially for underrepresented populations?
Yeah. So I think there's a number of things. One is, again, we've been looking at how we integrate patient engagement, patient-oriented research within trials, but also research more generally. So just to, again, follow on that point, we had great institutional leadership, but it was about then moving that into beyond the individual. So there's a number of examples that in my area where you've had strong leadership, that person leaves, and then it all falls apart. So I think what's been key is sort of moving it into the infrastructure that we have. So we actually have the Office for Patient Engagement and Research Activities written into the strategic plan for our organization. We identified that you can't make this extra work. So, for example, we have an e-notice of intent for grant submission. So we added a question. Do you have, or do you intend to have, patients as partners? And if someone checks yes, it filters to me or my office. We can reach out to the individuals. But then we have a measure, a metric to say, have we changed the culture? So even if I'm not the person consulting with them, we can track that data and say, how many grants actually had patients as partners? Okay, so if it's not coming to me, but we're seeing a growth in that, maybe it's an indicator of a change in culture around that. So I think that's been important for us. And now we're in a phase where, having made that first step, we're looking at, okay, how do we do these next steps? How do we look at who's being engaged? What are the equity issues there? How do we go out and make those links? Within the Accelerating Clinical Trials Consortium, part of the ways we've done this is sort of saying, well, how do we get beyond tertiary academic centres to the other centres where we know a large proportion of care happens? How do we get research into those? So again, there's things like funding positions in those centres that allows trials to go to the people. Interestingly, we have a real challenge in Canada to fund methodological and implementation research that isn't tacked onto a clinical application. So in the UK, there's a Better Research, Better Methods funding stream specific to say, how do we implement these things? To do research, to look at how do we get these things taken up in practice? How do we embed research in care? We don't have that in Canada. So again, there's things like that where we can make changes, hopefully. But as I say, trying to get into those centres, into the areas where people are, to try and then get the research to them.
That's an excellent point, and we haven't seen the CCS report yet, but I'm hoping that this is one of the recommendations, that this is a really important area of research that's needed in order to get the representation that we all want to see in the clinical trial space. Rebecca?
Yeah, I just wanted to add two important drivers, I think, potentially from the sort of policy and regulation side of things. So Health Canada, as people may know, has had for years now the Sex and Gender-Based Analysis Plus aggregated data requirements, reporting requirements for clinical trials, but they have committed to adding and expanding that by adding disaggregated data requirements. And so I probed Health Canada on this just recently in preparation for this, and they said that it's going to be part of the clinical trials modernization initiative, which the next step of providing the final guideline is meant to be mid-2026, I think, was what I heard. And then also just, I'm sure people in the room are aware, but just in case, is to say that CIHR at the end of September signed on to the World Health Organization's joint funder statement, which really broadens the commitment around having more patient engagement and also representative patients included. So just to highlight that both of those hopefully will then drive reporting requirements as a term of funding, et cetera, which will also feed into some of the change we need.
Yeah, great. Thank you for adding that, and thank you for asking Health Canada this question. So moving to our discussion on training and capacity, so culture evolves through education and leadership. So we're going to talk about the needs that we have with respect to building up our capacity, and this is achieved largely through training. So Rebecca, I'd like to start with you and specifically how your organization, N2, is approaching the integration of trial literacy into clinical and research training.
Well, so one so our courses are a pretty deep dive. They have historically been really serving those individuals who are in charge of operationalizing or supporting those who operationalize clinical trials. So they're quite detailed. However, we recognize the need to have, we're just calling it at the moment, a 101 kind of level course that touches on, from start to finish, the why of research, and then a light touch on, the ethical considerations, GCP, et cetera. And the audiences that we thought this would fit would both be people engaged in the health system in clinical roles, right, who are hopefully more and more going to be asked to participate in a portion of trials, but also patient partners who we know it's only right that if they're invited to participate in a research initiative, they should feel like they have access to education materials so that they can fully participate. So that's one piece that comes to mind. We're always developing new topics as well as new areas of clinical research are emerging. So for instance, on real world data, et cetera. And I did also want to highlight that, as people may know, and you may be just kind of covering your ears and your eyes to not pay too much attention to all that is in the ICH revised GCP guideline, R3, which Health Canada has announced it plans to implement effective the 1st of April. But baked into that are the concepts of proportionality and risk-based approaches. So all of this is meant to support more innovation, more people coming under the tent of research and participating. And so our courses, for instance, are now all being updated to align with R3. So I think that's a really important development that feels boring and prescriptive, but I think does promise some exciting change.
Thank you for that. Dean, how do we ensure frontline clinicians have both the skills and time, big one, to embed trials into care?
Yeah, so I think a lot of the training is going to come through the awareness of all the the personnel within the hospital about research and the value of research through onboarding, but the more regular educational sessions that they would have as part of their job roles. I see that as a big one, because that's how that will lead to that cultural change, that awareness and familiarity and what to do. In terms of clinical trials specifically, there's a lot of good training out there. Obviously provided N2 for our research professionals, but there's a lot of work that's being done through the SPORE initiative on patient engagement, alternative modes of consent. The materials are there, but it gets back to that action plan and integrating those materials and training. But the biggest one is to that cultural change throughout the hospital. It requires that awareness, and I fit training in there as well.
Yeah. Rebecca, Dr. Auer brought up yesterday many times that the lack of requirement of clinical trial education in achieving their medical degree,
yeah.
And that it's not required. Is there any work that is being done to include that as part of the training?
Yeah, there is some work. Funny enough, patients are also driving that too, right, in medical education and that. But there is some work. There are some programs locally at the Department of Medicine. They've got a program called Research Plus that they pick out medical students that have an aptitude and passion for research, carrying that into their residency and training around that. And those will be our leaders. Those will be those transformative leaders, hopefully. But certainly more can be done. I think there is a bit of exposure to clinical trials, but it's, might be a few slides and that's about it. I don't think they make the connection with care until they're out there practicing.
And they're practicing, indeed. So lots of work to do there. Susan, question for you with respect to the competencies that ethics committees and coordinators will need as we move towards a learning health system. What do you envision?
Yeah, so that's a really interesting question. And, you know, at this point in time, there's not a common pathway for training when it comes to research ethics. So whether it be board members or administrators, et cetera. With that being said, I see more and more initiatives talking about this. Like, should there be, you know, more, I guess, structured expectation for folks that are involved in research ethics review? I'm looking at Natasha as I'm saying all of this. It's an interesting thing because I'm sure, like you know, I was introduced to ethics boards years ago, and the first days you walk into those rooms, it's like, oh my gosh, how do these people know all this stuff, and how can they talk about this so intelligently and get to the bottom line? But a lot of it is just, it's been through experience. So all of that to say, there are some extraordinarily, wonderfully competent, excelling beyond competent people that work in this field without ever having really specific education and training around it. They've learned it experientially. On the other side, I'm not sure about the rest of you, we find it hard to find and hire people with the competencies that we'd like to have around research ethics review. I think that's a matter of it becoming you know, us needing more people in that field, right? The needs for more people in that field and how much more complicated it's become. When I first started thinking about research ethics, well over 20 years ago, it was a completely different ballgame than what it is now. But again, there are good conversations going on about training, competency programs, you know, classification of jobs, et cetera, that I think will be coming on board over the next years.
Thank you. So we're approaching the end of our time, and I gave an almost impossible task, but they are completely up for it. So with respect to embracing the shift, and this is a question for all of the panelists, what does success look like in 5 years? Sure.
We have a single research ethics review of multi-site clinical trials in health research in Canada. A high-quality single review. No legislative barriers.
I come back to the institutional leadership. Buy in to research is care. We need to start there, as I mentioned. And I think that's beginning to happen. And again, data, patient partners are huge drivers of that. So I'll leave it there. I mean, there's other markers of success in terms of enrollment into research and trials and so forth, but we need to start there to move the needle.
Yeah. And to make that economic case, and again, pointing to Kurt and those CEO KPIs and ensuring that they're showing up there as well, that they're evaluating that, they're responsible for implementing this as well. Thank you. Stuart.
I think it'd be a case where patients coming into the hospital know research happens and are offered opportunities that have been co-designed with patients to get over those barriers, to make taking part in trials feasible and improving that access to clinical trials.
Thank you.
And just obviously, I totally agree with everything that you've all just said, but I think the ultimate would be having Canadian patients accessing therapies, good therapies first, and with shorter market launch times. And I think that as a community, we have to stop just leaning into those favored stories, and I think in many cases myths about why that is not as fast as it could be in Canada, around Health Canada being slow. We have a 30-day time frame for getting no objection letters. Ethics being slow. We know that in many cases it's not the ethical piece at all, and Can Review is only going to make that better. And really digging into the other aspects. I just learned yesterday at a talk, and have not validated yet, that it looks like from the data I saw that actually one of the biggest bottlenecks is the pricing negotiations that happen after the research, after all of the approvals, after CDA. It's that last step where things are getting stuck for months and months and months. So all of us becoming more educated and really getting beyond just those same old stories that we repeat to each other. because it feels good to complain about groups.
But yes, we need to move on,
Yeah.
right? We need to move on in our discussion. So thank you. Fantastic discussion by the panelists, so thank you so much. And so what we've heard today is that embedding research within care isn't simply a technical challenge, which will be discussed a little bit later on today, but it's a cultural one. And it very much asks us to rethink our ethics, retrain our workforce, and redefine what it means to provide care. So please join me in thanking the panelists for this amazing session. And yes, are there questions from the audience?
Thanks. I'd like to put a few challenges to the panelists. And first of all, I'd like to say you're right. PCPA takes way too long to negotiate, and there are lots of ways we can fix that. So it is one of the problems, but I assure you there are problems before that we shouldn't overlook. However, my two challenges are to the two other doctors that spoke here. Dr. Nicholls, I don't know you, but so Dr. Nicholls, I didn't get an answer to the question about underrepresented populations from you. I got an answer that said we put a check mark where there's patient partnerships, and that somehow makes us feel better about things. But I didn't get an answer that you have a real plan in place to ensure underrepresented populations are in research. And I also have a challenge for Dr. Fergusson. Although you said towards the end of your presentation that research is care, I wrote down earlier, very early in your presentation, you talked about research versus care. And I think as long as we talk about research versus care, we're not talking about research as care. And I think we need to take that dichotomy out of our vocabulary. I can assure you that research is care. It's a certain type of care. It requires a certain type of ethics, as you know, and a lot of requirements around it, but it is definitely a part of the care continuum. And I think we should take the versus out of any sentences that talk about research and care.
Thank you, Louise. Vaj?
Yeah, thank you for that interesting discussion. I will have a comment regarding more on the training aspect. So it's great what N2 is doing, and I just had a quick question before I make my comment also. How easy is it to access these trainings when it comes to the hospitals, institutions, research providers?
Yeah, so N2 is a member-based association, so all of the large clinical research intensive organizations in Canada are N2 members. So if you're affiliated with a university or a hospital, it should be very easy to access. And if ever you get stuck, just get in touch and happy to help.
Okay, great. So follow-up question, because as a CRO, we are very heavy on training as well, of course, when we have new employees coming in and even more senior employees sometimes that come into the organization. We need to kind of check the boxes to make sure that they are qualified to do their job. But we also make sure that instead of just providing training based on, let's say, read and understand kind of training or self-directed training, we also have mentorship, right? Is that something that is part of the N2 training program? And it's not just about N2, but I would also highly suggest and emphasize that any type of training, whether it's N2-led or not, have a mentorship program associated with it. And what Susan said before with regards to ethics, reviewers, for example, they have this wealth of knowledge and experience, and we have to lean into that. Whenever we have people in our organizations that have that knowledge and experience, utilize that in order to mentor and help the next, let's say, generation of individuals that want to continue. So do you do that in the...
Yes,
Okay.
so I totally agree with you about the importance of mentorship. We do have a mentorship program. I will say, if I can speak candidly, that my perception is unless the home institution enforces participation by mentees, we have so many passionate mentors in the N2 network who, before they leave the workforce, really want to pass off all of their passion and expertise. But my sense is that on the mentee side of things, it's really just those institutions who are making it a requirement as a part of their training pathway with them that they participate, that happens. I mean, of course, there's always a few keeners, but it's like anything. If it's optional in our busy workday, often doesn't happen.
Great. And last thing. Also consider, and this is something that in the US, well, globally as well, the association ACRP has championed for a while now, is competency-based training and hiring of individuals. So it's not just the required, this was
2
a while
years
ago.
Canadian experience, exactly. Yeah.
Really focus in on the competency-based career advancement and training.
100%, and I'll just take just 20 seconds to say that N2's helped to kick off a national initiative just earlier this fall with participating supporting organizations like CTO and Clinical Trials BC, and it's all around, we're calling it the Clinical Research Workforce Strategy, and it's around standardizing job descriptions so that organizations will know usually a JD for clinical research is sort of a dog's breakfast, and you kind of wait and see who applies and if there's a fit, and then all of the downstream problems that creates a mismatch between expectation and role, and the person leaves and the study gets delayed because they're without staff for years. And so just to say that that's something that we're working on, and the plan also, so it's 3 things. It's the standardized job descriptions. It is having defined career pathways based on competencies, not based on arbitrary things like 2 years Canadian experience, and also establishing a national occupation code so that the CRP role is more visible, for instance, to internationally trained medical people when they're coming to Canada, that they see this as a good fit potentially for them to not have to retrain. And we're looking for more people to champion this initiative, so happy to talk that, Shay. Okay.
Great. Thanks very much to the panel. My name is Cynthia, and I wear a lot of hats, and 2 of them are clinical trials training and research ethics review. And so this has been my Roman Empire this question has been my Roman Empire since signing up to this, since registering for this conference, and here it is. So if we're training researchers, clinicians, CRPs, communities, patients, that research is care and care is research, are we sidestepping the unpredictable nature of research? We don't know what's actually going to happen by relying a little bit too heavily on the informed consent process.
As I mentioned before, I think all those safeguards have to be in place, but I think there's great efficiencies in streamlining the consent process, making it appropriate, relative to sort of the risk of the study or entering a study. So for very low-risk trials, of which is the vast majority, having those 50-page consent forms, which all people don't truly understand, and it just creates inefficiency. So I think, verbal integrated consent, make use of the electronic medical record, electronic health record by integrating consent in there in terms of that two-way conversation with the clinician, that if they agree to be in the trial, it's marked there. Through MyChart, so the patient portal for accessing their health information, that they want to be part of research or on a particular study. All that should be there, but the safeguards also have to be there. And so training with research ethics boards and their familiarity with these systems. I mean, we're very, very fortunate. The Ottawa Hospital has had a very progressive REB that's entertained these ideas and helped lead to the creation of the REACT program because they understand the issues and they realize that they can be barriers to further research and democratization of research, getting to not just the typical patient but all patients. So I think it's fair. I mean, I do believe research is care. I don't want to take that verses out and research is care. but we need to streamline and make it much, much more efficient. No.
Nobody's worried about therapeutic misconception?
I do, yeah, absolutely. Those are the safeguards. I do. That people have to realize why they're going into a trial and the purpose of the trial. But keeping in mind that that's a thin edge of all trials.
Almost like a litmus test, right? Of like.
Yes, yeah, but if you embed it within a culture of research, an environment of research, people will understand those concepts a lot more. Or for the next time, they'll understand it a lot more. Yeah.
If I could just add to that, I think there's so much more room for research and work on asking participants that question. Like for this type of trial, did that informed consent process work for you? Did the form work? You know, did how it was introduced to you? To all of, you know, all of the pieces of the process. I think that's a part we don't do enough work on.
Thanks, folks.
Thank you. Well, 2 more questions
Yep.
here.
And you? Oh.
So this may be a naive question, but in the spirit of challenging questions, I was wondering, what do you think are the challenges and the barriers to moving towards a central national research ethics board, contrary to what we have now, institutional and provincial REBs?
Okay, so you know, for those of you who know me, know that there's a large group of us working on that right now. So I guess I put it in, you know, the main barriers, I'll put in 3 different categories. One, there are some legislative or government directives in some provinces that restrict ethics review to the boards in those provinces, but that's only, I shouldn't say that's only, that's a couple provinces that fall into that category. And working on this issue for years, another thing that we find is that institutions have their own ways of doing things. So if you're dean and you're at the Ottawa Health Research Institute, there'd be one system probably that you go through, and you go over there to talk about one thing and go over here to talk about your research ethics review, and it's all together. So people letting go of using an in-institution system and moving to an extra institutional. I know this sounds like it's in the weeds, but honestly, this is one of the main barriers that we've seen. And that's why I was very interested, Kurt, in wondering how you got to where you were and how you got over it, but you haven't gotten over it yet, so you need to come back in 2 years. Maybe we'll be able to tell you how we got over it. I don't know, one of the two. But the third piece that I would say, like, it comes back to that institutional leadership part, right? Now, with that being said, getting institutional leadership to say, yes, this is a good idea, we can do that a lot of the time. But without their reinforcement, support, and an action plan that recognizes the hard work of the people that work within their organizations, it's difficult. What we find with initiatives like this is sometimes you think they're going to die on the vine from 1,000 cuts. You know, there are so many. And I like the way that you talked about the stories versus the facts and the things. Like, so many of the stories come into this. And without institutional leadership sort of saying, I hear you, I understand that story, here are the facts, how can I help you move forward? It's a bit of a barrier from that leadership to the, I would say, to the 1,000 cuts issue, which are things I think we can get beyond. Support from groups like this are really supportive. Colorectal Cancer Canada is a CAN review partner, which we really are grateful for. And many of your organizations and too are CAN review partners. So I would encourage anyone who's interested in this to please become a CAN review partner and help create really that groundswell of support that will convince our leadership to work with their teams and their folks to get this done.
Great question. And a new?
Yes, canreview.ca. Thank you, Dean.
We're part of it, yeah.
Hi, my name's Anusha Jones. I'm from BioCanRx. My question is about leadership competencies. These are changing times. I'm going to pick up on some patterns that I heard throughout the conference. Yesterday in our small group session, there was a comment about how leaders need to recognize what the trade-offs are in order to be able to buy into a system of change. Leaders that I've talked to in the past have talked about the importance of understanding human behavior for leadership. the importance of psychology, the importance of humility. And so my question for you is, we're talking about research as care and care and research, and as a bureaucrat, those are two very different funding programs. They come from different places, they have different objectives, they have different KPIs, they have different timelines. What are the unifying competencies that, to pick up on something you said earlier, Susan, about experience? Because I think we're looking for unicorns. So what are the kinds of competencies that you would want to see in our leaders in order to meet this moment of change?
Grasping innovation.
What do you mean by that? Because innovation is one of these awesome words. That,
it's being open to a learning environment, always a learning healthcare environment, opening to new ways of doing things. So much. By the way, I don't work in a hospital. This is hearsay, but so much you hear that when it comes to, things like procurement, goes off to a procurement, office that just gets, takes the cheapest price for everything rather than thinking about what might be better for our patients in this case. What might be better in the long run for costs, but we might have to, provide more support in the beginning. But I think if they're really in support of innovation and improvement, real quality improvement, research and care fit both very nicely into that bandwidth.
Maybe just, I'm not sure if it's a quality, but it's the acceptance of patient engagement. So hospitals, particularly in Ontario, but other provinces, they've, through the patient partner advisory councils and panels, depending what they're called at the hospital, they've become more and more conditioned over the last dozen years on patient engagement in their governance, in their committees, in terms of patient satisfaction, patient experience.
So what is that? Sorry, but what does that look like when the demographics are changing? And to Louisa's point about underrepresented groups, I think about my parents, right, as a population that I don't ever see represented. Yeah. And so when we talk about leadership, when we talk about patients and accepting patients and engagement and patients, the thread goes through of how do we meet this moment of change?
Yeah, I don't know how to directly answer your question. I think it's just embracing that patients is not one voice, it's many, many voices, and not just patients, but communities, which those patients represent and so forth. But just having that aptitude for understanding how that fits into the system, right? And I think it's vital because it's leading to those changes. And we came along and Stuart and I said, well, that patient engagement, those patient family advisory panels within the hospital, they're not even touching research, right? Not, maybe some coming close to quality improvement or quality assurance work on committees or panels and so forth, but not research. So we started to fill that bucket, utilizing that infrastructure in their budget, their line item in the hospital budget, of embracing research, and we can fill in what we need to from the research side. So I think that's going to continue. And so it's that aptitude for hearing the patient voice, but also the community voice. I could speak at length. I think we need to do a much better job at reaching those communities about the healthcare system, but then also research and participation in research, because that's a divide, and we have not given attention to that at all. And so our typical patient partner fits one or two demographics, right? And it should. We do need to work on that, but I think the only way is working with those communities, not just expecting it, but working with them.
I was just going to add, and you may be well aware, but the Canadian College of Health Leaders has a pretty comprehensive framework for leadership called LEADS. Each letter stands for something. Innovation is one of the areas touched on, and cultural competency is another. So just to say that if you're not familiar with that framework, it may be of interest.
Thank you.
Thank you.
Yeah, I just wanted to follow up on Stuart's comment. It was very short, or it's actually a question on how to go from the academic centers to the community, not only to reach different communities, but actually to spread the reach of the clinical trials into the non-academic centers. This to me is a very fundamental question. We heard that telehealth from Kurt is not working all that well, but we do have a great example, and I think we have to find those examples within our country at the Jewish General Hospital, and Taevong is here from there, where they have a home, sort of a control center to follow patients at the home. Well, we could integrate that, or at least they could integrate that, into a clinical trials program by capturing the data. I think that's, you kind of talked about the data, but we don't have a infrastructure, available to collect that data, notwithstanding the health strategy, data health strategy in the country. So I think that we have to find those examples, whether it's the project at the Jewish General or others, Ottawa Hospital's use of data, the electronic health record systems that don't necessarily exist, for example, in Quebec. But we need to find those pilot projects to exemplify the point so they can be replicated across the country. And I think that's about the only way we can do it, because right now I feel we're talking largely to the big academic centers. We're not talking about a community center, in someplace Ontario, right? We're talking about downtown Ontario, essentially. So we have to think about that, make that a focal point of the strategy as well, if we're actually going to accomplish what we say we want to accomplish, but truly bringing research as part of care.
Thank you, Barry. I think we're going to end it there. Stephanie, expert guidance, thank you. To Rebecca, to Stuart, to Dean, and to Susan, thank you. We're going to I'm going to give you just a quick break so that we can move into our next panel. So please, if we could ask the next panel to come on up and grab a quick coffee and come immediately back to your seats. Thanks. We're going to leave this question up. So as you grab your coffee, this is also a question that we'd love you to, again, give us some input on. What cultural shifts are needed most to make research as care and care as research a shared value across institutions? So as you get your coffee, love to see your answers.